get started. So my name is Marcia Castro. I'm the chair of the department, and it's my great pleasure today to have Dr. Elisa Maffioli, who is going to be the seminar. She is this year a visiting assistant professor in the department. So if you haven't met her yet, please stop by the 11th floor and say hi. For all the students, she's also holding office hours to help you with methods. So please stop by, say hi, and take full advantage of all the resources she's willing to share. Before I pass on to her, I also want to acknowledge and welcome all the team from the Quest program that is led by Professor Crook. I believe we have representatives from let's see, Ethiopia, India, Kenya, South Africa, Latin America, and Mexico. So welcome to all of you. And I think we also have a representative from the Gates Foundation. Thanks so much for being here. I hope you enjoy your time at GHB, and I hope you enjoy this 1 hour of our regular weekly brown bag. Thanks, Margaret, for bringing the team to join us for the seminar. So, Elisa, you have a very special guest today. No pressure. So
Try to do my best. Thank you so much for the introduction. Okay, so let me just say briefly, I'm happy to take any question during the talk if you want, and then I will leave the time for a question at the end. So since I'm here, I just wanted to give you a brief introduction about myself, especially for also the students if they are around. I'm an economist by training, and I study different global health challenges that poor households face in lower income countries mainly. I'm very much interested in addressing or trying to address different social, economic, behavioral, and political determinants of health through socioeconomic policies. As a standard economist, I guess, I use different methods. So from quite experimental methods using administrative data to collecting my own data in the field to kind of large randomized controlled trials in collaboration with local partners. I work at the intersection of infectious diseases and maternal and child health and across different countries in Africa and India and Myanmar in Southeast Asia. So I have two broad areas of research and interest. The first one is really try to looking at the effects of social economic policy on population health, thinking of addressing specifically financial and information constraints. So I work in malaria, improving malaria treatment and testing in Kenya, as well as combining cash transfer with social behavior change communication, try to really reduce chronic malnutrition of children in the first 1,000 days of life. My second area of research, which I'm presenting some of my work today, look at how government or political factors shape investment and how that could translate into health. I have a few papers on kind of the allocation of resources in Brazil, but a lot of my work has been focusing on epidemics, specifically the Ebola epidemic, one of the countries that has been mostly affected back in 2014-16, Liberia. So a few years back, I looked at how the government strategically allocated resources during the relief effort that was provided during the epidemic. And today I'm going to give you some evidence on the importance or the role of mobile phone technology and how can we do a little bit more in terms of investment to maybe contain the next epidemic. So that's in a nutshell basically the talk today. So if you're already bored, you can zoom out completely. If you're still with me, I'm going to tell you a little bit more about this specific research. So this is just work with Robert Gonzalez. He's at the Georgia Institute of Technology right now. So let me start from the motivation. Infectious diseases are still common and are specifically a concern for lower and middle income countries. We face the Ebola epidemic, a resurgence of it in 2018, the swine flu. Latin America was affected by the Zika virus, and of course, we're still facing COVID-19 pandemic. So assessing the effectiveness of certain tools that could help contain or the next epidemic are very much important and should remain on the agenda of policymakers. I think everyone in the room could or should agree that mobile phone technology could be potentially one of those tools that are very promising for public health. They are cheap, they can reach people in their homes, they do not require steady electricity, and there is some potential for it. So a low-income country, about 50% of the population own a mobile phone. And actually 90% are covered by at least mobile cell phone networks. So they're able to send a text message or able to make a phone call. In the past, there's been a lot of literature and a lot of studies to try to look at specific tools and how those tools, like some specific mobile app, could help contain or certain outbreaks and specific diseases. But right now, the question that we are asking is way broader, and it's really thinking about a population level, thinking about whether cell phone access among the general population can actually help contain or even potentially spread disease during an outbreak. So I'm going to tell you all the details about it, but very briefly, what's the context? We're taking advantage of the 2013-2016 Ebola outbreak in Liberia. We are using mobile phone coverage as a proxy for mobile phone access, and we are going to use, in terms of identification strategy, a regressionist continuity design with the whole objective of trying to find the causal effect of mobile phone access on the likelihood of having an Ebola case. Okay? So just to tell you where the literature is and how to improve from what is existing today. So there is a bunch of literature in economics that really look at the role of information and communication technology and how that improves economic development. Within, kind of the literature in public health, there are a lot of studies that look at the relationship between mobile phones and health-related outcomes. Whether mobile phones have been used to improve the management of the records or monitor a certain situation, or doing diagnosis of a certain disease, or even improve maternal and health indicators. There is even a literature that kind of focus specifically on infectious diseases per se. I don't know how many of you are familiar with the so kind of called participatory epidemiology, but mobile phones have been used to track people, to do surveillance, to get information from the communities. And there is also specific literature that look at how we can exploit mobility patterns and kind of phone connection to really predict an outbreak. So we're contributing to these three strands of the literature. And on the methodological side, we're also kind of trying to improve on the radio wave propagation model literature. This literature views specific models that I'm going to tell you a lot of details about in a few slides to proxy for media exposure. But while these methods have been used for TV and radio, it kind of lagged behind in terms of phone communication. So we're going to estimate the model for it, and we're going to embed these that we think is new in a regressionist continuity design to get at that causal effect. So what do? We measure mobile phone access at the large countrywide scale. As I told you, a lot of research is focused on specific mobile app, and specific disease, and so on. So this is a very general question that we are asking here. We try to address indigeneity of cell phone access. So I think, people that have a phone and people that choose not to have a phone are different on certain characteristics. So we are trying to really disentangle the effect of cell phone access from the other determinants of the technology, why people choose to buy the phone. We improve on the signal strand estimation, building on the most recent type of model, and really thinking about how we can estimate the model for Liberia, for the type of network that Liberia had at that point in time before the Ebola epidemic. So it's quite accurate compared to what the literature has been doing. And finally, I think we go beyond a little bit the evaluation exercise of looking at the relationship between mobile phone access and whether there is a case of Ebola. We also take a step forward, and I'll try to tell you a little bit more about the mechanism, thinking about why we do see cell phone access contain the epidemic and how this could have helped people to get more access to preventive care, treatment care, or either spread or contain the epidemic along the network. Okay, so let me jump right into the background. So just to give you a sense, we are in the context of the 2014-2016 Ebola outbreak. I know this number seems completely minimal now after you see the number of COVID. Liberia was, at that point in time, as 3 million people in the country, but this was the largest epidemic of the history. in the history of the Ebola disease. So about 11,000 people got affected and about 5,000 people died. That's the largest number of deaths across the 3 countries affected by Ebola, Guinea, Sierra Leone, and Liberia. Just to give you a short summary of what happened, the epidemic was very much kind of underestimated by the government as well as by the international community. The international aid arrived, but arrived quite late. The government kept ownership of this relief effort and tried to allocate resources as best as it could. Few of the relief efforts that were provided were a hotline number that was set up for people to call or ask for someone to come, either send an ambulance or come and get some of the sick people or dead bodies. They set up community care center. They built Ebola treatment units. They also send out burial teams to make sure the community knew how to properly treat a corpse for the funeral. In terms of mobile phone access, about 65% of the population back in 2014 or 14 as a mobile phone. And here we are talking about a 2G network. So people that have access to a phone can only send a text or make a phone call. So we're not talking about internet or data access. So the context is quite different of what we can think about what happened during the COVID epidemic. This is how the epidemic looked like, just to give you a sense about our study period. So on the x-axis, you have the timeline, and on the y-axis, you have the number of cases of Ebola weekly. So what you can see, the first case appeared at the end of March. The first wave was basically contained in 1 month. It appeared at the border with Guinea. However, after that, a new case at the end of June appeared in the capital city, Monrovia. The capital city is the economic hub, so 30% of the population live there. So once the disease reached that, the capital city basically exploded very quickly. So the President Cyril tried to do the best she could with the resources, so closing the border, closing the school, quarantine some of the slum area around the capital city. And after that, after the declaration of emergency, actually the international community, the US government as well responded. So a lot of the relief effort actually was sent when the epidemic was already slowing down. And by the beginning of 2015, there were fewer than 10 cases per week. And over time, it basically went to zero with few outbreaks in 2016, but very minor. So the study period that we're looking at is March 2014 until July 2015. It's where I have my data. So in terms of the data, what I'm using for defining Ebola is a proprietary patient database that I was able to gather from the Ministry of Health. This database contained about 19,000 patients that were tested, suspected for Ebola. I supplemented some of this data with another important organization that helped the Ministry of Health to manage all the burials since July 2014. And after a lot of cleaning and so on, I was able to basically get a village level database where I would be able to see every case of Ebola, whether any village in the country was affected by Ebola or not. So all the results that I'm going to show you today, for simplicity, are just measuring whether there is at least one case of Ebola in a village, but they have a bunch of kind of robustness check looking at the number of cases, how many months the village was affected, and that as well. In terms of coverage, we were able to gather data from the Liberia Telecommunication Authority back in 2013, so before the outbreak. And the data are coming from the 2 main companies, cell phone companies in Liberia, so they cover about 91% of the market share. We do use the data on the towers and all the characteristics I'm going to tell you about to try to measure signal strength on the ground. And we do that through an irregular terrain model. So what is this irregular terrain model? It's a radio wave propagation model that basically predicts signal strength. So you can think about this very simple way. The easiest way is that there is a tower, and then some people around the tower, very close to the tower, are able to make a phone call, get the signal on their phone, able to make a phone call, send a text message. Farther you go, less likely you're able to communicate with your friends. So this model is kind of the fourth generation of this model, starting from this simple model that kind of just as define a radius around the tower. This model is one of the best models and is better suited for the super high frequency wave, the wave for the phone and not the TV or radio. It's also the main model that the US and other regulatory agencies are using, and is actually validated via on-the-ground measurement. Once the model predicts the signal strands, people are actually sent out to do what is called hand-to-head validation. So people are actually out with the phone and try to see whether this model is working appropriately. So the model uses a variety of inputs on transmitter and receiver characteristics, as well as elevation, climate, rain, conductivity. So I'm going to show you exactly which level of details we are going to get. But the output of the model, that is what we are using in our regression, is basically power received in each point on the ground for the entire country of Liberia, defined in decimal milliwatt. So for simplicity, we use the absolute value, so lower decimal milliwatt is actually stronger coverage, but it's very easy to interpret. Let me tell you right away whether it's so important to do this model. Why do we care about doing this model? Why should we care about the topography? Why we cannot just assume, direct line of sight from the receiver, from the tower to the receiver? So this is the simpler version of the model. It's called a free space model. This is a random part of Liberia. Each green dot is a tower, is a cell phone tower. So what this model does is basically just predicting by direct line of sight what's the signal strength from the tower to your cell phone. As you can see, it's very easy. Closer to a tower, you have higher signal strength. Farther away, you have less signal strength. Maybe you're not able to make a phone call at one point. It's this kind of easy and linear. But this is not the level of granularity that we care about. What we're trying to do here is really try to look at all the changes in the topography and thinking about how signal strength change based on the topography to try to isolate the effect of that on the Ebola epidemic. So this is what actually our model does. So it's going way more in details. And so the idea is that if you are on a certain elevation, on a hill or not, if there is a forest or a tree, if it's raining, or there is certain climate in an area versus another, is more humid or is more rainy, that your cell phone is not working so great, or depending from compared to other areas. So what we're trying to get is really these minimal comparison or minimal kind of granularity, so that we can predict exactly signal strength in each point in the country. So what the model does is just Liberia, to give you a sense. The green star is the capital city. All the blue dots are tower. So it shouldn't come as a surprise if you know Liberia. The north and the south, there is no tower. There are no villages actually there. They're very much forest area. So what the model does is basically predict signal strength everywhere, and that's exactly what we're going to exploit. So it's not so straightforward, right? Because you can think about the quality of communication to be a continuous function of the power received. But what we're trying to exploit is the discontinuity, that's the whole idea of the regression discontinuity design, in the ability to make a phone call or send a text message. So the cell phone tower or the cell phone network usually work between 95 and 105 decimal milliwatt. The cutoff the technological cutoff that we're trying to exploit here is basically going from 0 bar on your cell phone to 1 bar. And then we will control whether you have 1 bar, 2 bar, or 3 bars. So what is the idea? Is to compare villages that are very close to this technological boundary, that should be very similar in terms of demographic characteristic, economic characteristic. The only difference is that there is the topography basically. There are minor changes in the terrain, and the fact that there is a forest, in the climate. And so some people are able to make a phone call and some people are not able to make a phone call. So this is, sorry, it's quite small, but I can just walk you through it. Yeah.
Sorry to interrupt, just on the topography, what are the drivers? Elevation, forest, and then
climate, yeah.
That's it?
That's it. Actually, slope is what matters most. But yes, the model has a bunch of inputs on that dimension. Any other question?
So
Yes,
are
please.
the, in how it's usually applied, the variation comes from, the running variable
Yes.
really comes from policy views variation. In this case, I suppose even if we can argue that the coverage, there might be a discrete change in the coverage. Location of cell towers and it's not exogenous.
Mhm.
So you can think about cell towers being located in places that maybe economically more well off.
Yeah, that's correct. So exactly. So in fact, this model is way more advanced at thinking about the location of the tower. So absolutely, the location of the tower is not exogenous. So what we are actually exploiting is just the changes in the topography. So the model inputs a lot of different variables, as I told you before, including the location of the tower, the type of waves, the terrain conductivity, the climate, and so on. The only difference that we are trying to explore are those idiosyncratic changes in the topography. So if you are at the same distance from the tower, or you happen to be, let me say, a hill or not a hill, or like at 2 meter at different elevation, that's a type of change that we're going to exploit in terms of isolating that effect on the topography and isolating the causal effect on the Ebola measure. And so in fact, this is what we do see. So we are basically predicting what the signal strand is based on topographic control, some demographic control, economic controls. So of course, should not be as a surprise when we look at the entire sample of all villages in Liberia. Places with better signal strand are those who are at the lower elevation, closer to the tower, but closer to the city, or more closer to urban area, basically. People are better educated, have better house conditions, and so on. The idea here is that we're not estimating an effect on the entire population. Like the regression discontinuity is estimating a local average treatment effect. So we kind of look at villages that are across that technological boundary. So the only change is a change in the topography. In this case, the slope. But the model is more complicated than this, but like what really predict signal strand is slope. So we'll control also for slope, but the idea is really like if two villages are identical on all dimensions, but one happen to have people in a village happen to be able to make a phone call and people in another village are not able to make a phone call. Just because they happen to be on one side of that technological boundary, that's a difference we are going to exploit and look what's the impact on Ebola. This is clear. So in regression discontinuity design, as we were saying, the forcing variable is the receive power, and the cutoff that we are exploiting is this receiver sensitivity. So what's the right cutoff? What's the right technological boundary? So we, based on the engineering literature, we are using 95 decimal milliwatts. That's technological boundary for which you go from 0 bars on your phone to your cell phone on to 1 bar. So why 95? Because that has been estimated and validated in the engineering literature that that's the right cutoff for the type of network, a 2G network, and this type of 900 megahertz frequency band that are the only type of tower that exists in Liberia at that point in time.
Just a clarifying question. So if it's also related to the climate, is it then a matter of temporarily not having signal, or once you cross that boundary, you never have signal?
Yeah, that's a great question. So in practice, we are looking at the pre-existing signal strand. So for us, the model is estimating signal strand before 2014. So it's an average in our case. So we're not exploiting seasonality, every month and so on. We don't have a lot of variation to look at data every month. So we are looking at places that add different signal strand in 2013 and predict what the epidemic look like, or look at what's the effect of that on the Ebola cases that we see over our study period. Okay, so of course we did also our empirical test to make sure that our 95 decimal milliwatt is the right cutoff that we see in the data, and that's the case. So what do? We estimate the pretty standard regression discontinuity. Our outcome is whether there is at least one case in a village, I. What we are interested in is the coefficient beta, that is estimating the causal impact of whether there is coverage. Then we control for the actual received power. So we look at the difference from from having no signal to signal, but we also control for the type of signal that you are getting, the quality of your communication. We control for topography, slope and elevation. We choose the bandwidth optimally given the literature, triangle weighting kernel, standard error. I'm going to show you that the results are quite robust through a variety of changes. So the first thing you should ask me is that, do we see a jump, right? What do we want to see? Is there any effect? So I'm going to show you the pretty standard regression discontinuity graph. On the x-axis, you have the signal strand. That's normalized. So 0 is the 95 decimal milliwatt. So above that, on the right side, you have all the villages with signal strand, and below that, you have villages without. On the y-axis, you have the likelihood of having an Ebola case in the village. So what do you see? Two things. One is a positive relationship. So they should not be surprising. Places with higher signal strand are more likely to be urban. And that's also because of how the epidemic evolved. That's also where the likelihood of Ebola was higher. What we're very much interested in is the second thing that probably you observed, that is the jump. So there is actually a drop. And so places or villages with signal strand are less likely to report at least one Ebola cases by the end of the epidemic. Okay, so that's about 10 percentage points in the likelihood.
Do you ever see the first stage? Do you see like a direct measure of cell phone use, or it's all on the model signal basically?
Yeah, so we would love to see that. What we are able to do is just using the HS data and to see whether at the district level, the model is kind of correlated with ownership of cell phone.
Okay.
So we do see that positive statistically significant relationship, but the census data are 2008, so they're too old to look at that at the village level. So that gives us some reassurance that that's correct, but it's at the district level.
A quick question, what
Please.
are the circles?
So the circles are just representing the size of the bins. So it's a number of, is basically based or weighted by the number of villages in each, number of observation in each bin.
So the big circle towards the -20. you
There are
still
more
have a lot of
villages there.
observations.
Yes.
Okay, so there are still a lot of observations in places. where
Yes, we
signals-
were worried that it would be skewed somehow by the number of villages, but we do see that there's pretty balance across. Great. Okay, so let me show you this in a regression. The first column is exactly showing what I told you. That's 10, 11 percentage points drop. We do a variety of robustness check, adding control, using a second degree polynomial in the topography, using a third degree polynomial in the signal strand, changing the kernel choice, or estimating a probit model rather than a linear regression model. The results are pretty robust, and they are kind of, as you see from the column 4, when we increase the bandwidth to 50, so basically almost getting or using almost all the villages in our regression, the results are still kind of a 9.6 percentage points. They are quite more precise in terms of estimation.
So it's 10% decrease in Ebola case.
In the likelihood of having an Ebola case. That's percentage points decrease. Okay, so let me just tell you one of the main robustness check that we do. That what we're trying to get here is really exploiting all those exogenous changes in the topography, those idiosyncratic changes in the topography. So what we also can do is to control for what I showed you before, the free space model. So even assuming that direct line of sight from the tower to the receiver, controlling from that predicted signal strand, so isolating only those changes in the topography, are the results robust? So we do that, and very briefly, that's what we find. So even controlling for free space, coverage, signal strand, or interaction of the two, the result that is more in magnitude, but there's still about 8 percentage points decrease in the likelihood of having inequality. So I show you that there is about 10 percentage points drop in the likelihood. We do a variety of robustness check. Happy to, if you have questions, I'm sure some of them will come up in the question. So thinking about the bandwidth choice, alternate kind of using measure of Ebola on the intensive margin rather than extensive margin, controlling for physical distance, some placebo check, or really thinking also about people that would walk to a village with a cell phone, or like with the cell phone coverage to make a phone call. But what I wanted to show you in the rest of my time is really thinking about what are the mechanisms. We see a drop, but kind of what's going on and what is happening. So we try to test a few mechanisms. So you can imagine that cell phone access could increase access to preventive care, like information, of course, but also knowing accessing some of the preventive material they were sent to the villages, like buckets of chlorine and so on. And they could also help people to reach out, report cases, and ask for an ambulance or ask for burial teams to come to the community. So there was two channels that we refer as a care channel. They're really increasing access, or we think cell phone would actually increase access to either preventive or treatment care. And so the relationship between cell phone access and the likelihood of having an Ebola case is negative, as I showed you before. So there is also a possibility, and depends a little bit on how much you think a cell phone and person interaction are complement or substitute, that the relationship between cell phone access and the likelihood of Ebola could go in the opposite direction. So there is a literature that very well kind of describe that people with cell phone have a larger network. And so people with cell phone could actually tap into a network to get information or report that someone is sick, or organizing funerals, that it was during the Ebola epidemic. So it's possible that, especially at the early stages of the epidemic, actually the people would rely on their network because the government did a lot of effort, or like a lot of resources to do much. So depending a little bit on whether you think cell phone is substitute or not, this in-person interaction, the relationship could go in both directions. So I'm going to show you some of these. On the first two channels, I'm using some survey data that I was able to collect during the Ebola epidemic. Of course, working during the Ebola epidemic was tricky, so I couldn't go to the communities and do this in person. So what I did is to, using a platform and do random dialing of phone number, trying basically all the phone numbers in Liberia through some algorithm. And then when the phone would connect and a person would pick up, that call would be sent over to an NGO, and this NGO helped, doing a normal phone surveys. Of course, these are people with phone, but I wanted to keep in mind two things. One is that about 30% of these people did not have cell phone, were not living in area with the cell phone coverage prior to the outbreak. So that's a variation we're going to look at. Of course, you might be worried that some of these people at one point got access to cell phone, right? Because I interviewed them through cell phones. And so we're not using this regressionist continuity design. We are running a simple regression where we are exploiting the continuous measure of signal strength. So higher signal strength, what's the effect of having higher signal strength on these outputs, on this mechanism? Pretty standard regression. We also control for fixed effects, a fixed effect, and the free space model. So in the survey, I collected data on the preventive care and the treatment care, whether someone who came to do contact tracing, explain what Ebola was, or on the treatment care side, whether someone would come to take sick or dead people, like how close they were to a community care center, and whether the ambulance arrived within a certain amount of time. So what I wanted to show you is we don't find a lot of evidence, or like one directional evidence on the preventive care. And so what we do see when putting together these different measures on an index is that there is no statistical significant correlation between signal strength, just normalizing standard deviation, on a preventive care index. But what we do find is that there is some suggestive evidence that actually having access to cell phone as proxy by cell phone coverage helped access these ambulances and getting the community care center set up closer to their village. And so that's appear also in putting together all these measures in a treatment care index. If I still have 2 minutes, I'm just going to tell you about the network channel and the fact that we don't find evidence of it. We would love to look at the networks, as I think a lot of you imagine, and looking at the connection. We didn't have network data on our respondents, but we were able to come up with 2 measures of networks. The first one is really looking at or using call detail recording database. It is basically all the phone calls that were placed in Liberia in a couple of months in 2015. So we use those data, that's about kind of 300 million phone calls, about 1 million people, unique users. So what we try to do is reproduce the network based on this traffic of calls between towers and villages connected to different towers based on the number of calls that were made. And the second measure is more based on kind of the historical administrative regions in Liberia, and using the historical chiefdoms. So those are clans, that are a group of villages. Those people within the same clan are more likely to be interconnected because they share language, tribe, and so on. So the idea is that if any network channel exists in any direction you can think of, we would see some changes in the likelihood of Ebola based on the fact that some people would be connected by cell phone within their network. So we don't have to go to the details of the model. What I wanted to tell you is that what we are interested here is the coefficient delta that is basically representing the effect on the likelihood of having an Ebola case in village I. If within the network, there are other villages that are affected by Ebola, and those villages happen to be connected through cell phone network to this village, okay? And so it would be a positive coefficient if the cell phone would help spread the disease. It would be a negative coefficient. It would have helped contain. We don't find evidence of any of those. As you can see, the second row is really no statistical significant effects. We do see that there is a contagion effect, right? If villages were affected in the network, the village we're looking at is more likely to be affected. But we don't see there is any additional, either negative or positive effect of being connected within the network. Okay, let me conclude. I hope I show you that some evidence that mobile phone coverage helped contain the disease. This is true in the middle of a crisis in a country that was very much, with general mistrust towards government. And when we look at the channels of impact, what we do find is that there are some interventions that we believe that interventions that are designed to access treatment are more likely to be effective than intervention designed to increase prevention. Of course, this shouldn't be so much surprising in a sense that in the middle of a crisis, sending an ambulance that would take people and reduce the contagion might have higher return than just sending another text message and say you don't have to shake your hands. Another important thing is that I think here especially, we know very well that changing health behavior is quite hard, and so the prevention, even if people would access more information or more material on the prevention side, it would take longer for people to change behavior and to see that effects materialize. So it's possible also that our data, we don't see that in our data yet. So just in terms of policy implication, if it's not COVID, unfortunately, we will face something else. Hopefully not, but I don't want to be pessimistic here. And we know that the ultimate economics and kind of human cost could be mitigated through kind of the government action. So what we show you is that the cell phone coverage could play this important role in containing the epidemic, but what the government can do. We cannot tell the government to allow for private investment or investment during the epidemic, right? What we can do and what we can suggest is that in the middle of the crisis, people could exploit cell phone technology a little bit better to try to access the type of treatment or relief effort, the treatment resources. But what there should be doing in a normal period where we are not in a peak of a crisis is more investment in mobile phone technology. And so we think cell phone is a powerful tool for future epidemics. The situation changed quite a bit from 2015. 75% of people in low-income countries are now covered by 3G networks, so they could access even internet and data. But there are still a little bit more work that we need to do to think of reducing the urban and rural divide and the gender divide. But we really hope that cell phone could be exploited better for future epidemics. I still have 1 minute. I just wanted to tell you where my research is going. So I think my research is shifting a little bit in terms of looking at environmental factors, environmental determinants of health, and specifically the role of water and access to safe water. So I think, it was just in March this year actually that the UN set up the first conference on water in half of a century to try to reach Sustainable Development Goal 6 of providing access to water and sanitation for everyone. So a lot of my work is now focusing on access to safe water. With some of these, new resurgence of water-related disease like the cholera in places like Malawi, where there were no cholera cases anymore. So we are running a different randomized control trial to look at the impact of access to safe water and specifically chlorination and measuring the impacts on children mortality. So we completed a randomized control trial on the dispensers of safe water. Those are buckets of chlorine that mother or children that usually fetch water in lower middle income countries could get. While they get their water, they also get the chlorine, and by the time they walk back to their home, the chlorine is straight in the water and the water is safe to drink. So we're looking at the impacts of that. That's at the community level. And now we just started this year 3 large randomized control trial coordinated across 3 different countries. In Nigeria and Kenya, we're looking at the impacts of vouchers for mothers that come in at the public health clinics for antenatal care and will receive a voucher for a free bottle of chlorine they could go back and use in their household. Chlorinate their water for their household member and their children specifically. And in India, instead, we are working with the government that has this big mission, the Jal Jabal mission, that aim to get, as you can see from the picture, a pipe to every rural household by 2024. That's reach not 100%, but still 60%. So we're building on that government scheme to try to not only having households have access to water, but access to safe water through automatic chlorination. So ultimately, we're very much interested in understanding the effects and measuring these effects on children mortality, try to think about what would be the right investment to do in terms of cost-effective program, and how much investment should be more on safe water to try to save these children's life. Let me conclude. Sorry, I went over.
Thank you.
Questions? Maggie, really interesting. Thanks for presenting this. I'm thinking about the sort of, policy implications, and one thing that struck me is the finding around building treatment centers. So I don't know institutionally what this looks like, but everyone knows where you can't and cannot get cell phone coverage, right?
Yeah.
Like if you've been in a place trying to call into your work, or especially in time of a crisis, if I'm a health worker and I know my family's worried about me working on Ebola, like I want to be able to call them. How much do you think those decisions, are more about the supply side saying, well, it's easier for us for a variety of reasons, maybe that's correct or not, to locate a place for treatment where we can make phone calls, and that partly goes into it, which is maybe like has a different sort of interpretation about policy, because then it's sort of like, you might think, I don't know how generalized this finding is, that in times of crisis, like some of these treatment centers are actually being set up in places that already have more infrastructure, and maybe what we should think about is like, how do you make sure the place that doesn't have cell phone coverage is not, ignored because they can't call for an ambulance, or, so maybe you can speak to that.
Yeah, that's a great point. So the short answer is that we're not able with our data to exactly distinguish about those 2 mechanisms.
Yeah.
So I can tell you a little bit anecdotally what we know from the Ministry of Health and what we have in mind. That is the opposite, the fact that the mobile phone access allow people to report cases, and where there were more cases or there were kind of this lobbying at the county level, at the lower administrative level, to get that Ebola treatment unit built, or even that school be set up for a community care center. So that's kind of why I'm framing this way. We are not able to distinguish that, and it's absolutely possible that it's a combination of both directions. But what we have in mind is a little bit the opposite. Does it make
Yeah, that makes sense. But it could still be the case that if communities that have phones are better able to advocate for more treatment centers, that some policy recommendation might be that you need to go figure out what's going on in the other communities, or
Yes.
or you should send the resources there because you should assume you're missing something or something.
Yeah, that's a good point. Yeah, so it's absolutely possible. What we can see is that even in places that were very similar, and for other dimensions that were exactly the same in terms of other type of urban characteristic or access or education, whatever, or income or type of jobs, we do see that if the difference is only cell phone access, then it will be more likely to contain the disease. And so with the data that we are looking at and we are using, we think that the supply on other type of infrastructure, access to health facility or other type of public goods, access to school, we are kind of confident that like the data shows that there are similar other characteristics, but it's still possible. Yeah. So yes, maybe.
Yeah, I just wanted to ask about, you had a very nice graph of the time path of the epidemic.
Yeah.
And it was really striking that the epidemic basically stops after the emergency. But my reading of some other Ebola outbreaks is that they stop for reasons that are slightly mysterious. And Yeah, but was it really that the emergency was so were the actions are so intense enough and really so successful? My other point is, I really like the regression discontinuity approach. And I just wonder, if you know the dates of the cases, is the effect of the phone before or after the emergency? It might be that the mechanisms are very different before and after the emergency, and knowing when the phone was having the impact might give us some information about mechanisms.
Yeah, so let me answer your first question. So I think what people would say, what we observe in terms of the timing of the relief efforts, and is that a lot of the relief efforts happen at the end. So the government still built Ebola treatment units where there were no cases. So there was a lot of critics about like the allocation of resources and whether actually building an extra Ebola unit was needed in January 2015. So that's kind of, so it was definitely not the hotline save Liberia, not the Ebola treatment units, was a combination of a lot of factors. What is definitely true is that some of the response was probably not what slowed down the epidemic, because it happened quite after, when we were already at the fewer cases per week. In terms of your second question, so there was let me say in terms of you mentioned the emergency, right?
Right. So is the impact of the phone happening before?
Yes. So
the rising phase or the declining phase?
So we look at whether the effects were driven by before or after that red line. So a lot of it is coming from the second part. So most of the results are coming from the response for after. So there are two caveats, however. One is that, and that was part of our story, but we were not able to exactly pinpoint that effect, that the hotline was set up at that point in time, and it was very much effective. So part of the response could have been people be able to actually call this phone number, and this phone number were connected to the Ministry of Health, sending out ambulances and so on. So that might be. There is one other caveat that is important I want to highlight, that in the first part of the epidemic, there were not many cases, so like not a lot of variation. And so I'm not sure we have enough power to pick that up in the first part. But a lot of what we observe is coming from the second, from like after the peak.
So can I follow up
Please.
with a question? Then when the variable that you constructed, if there was at least one case, it was after the hotline was created or ever?
It was ever. And then in the previous version of the paper, we also have like before or after, still as a likelihood. And the effects are coming from the ever case after September. Yes. Please.
Yeah, no, thanks a lot for the very nice presentation. I was wondering, it's a more general question. Besides the study, have you thought about what's your next steps, maybe other epidemics, other settings, some actual mechanism question?
Yeah. So I think as my work is going a little bit in the direction of water, I think I would be very much interested in thinking about some of these type of investment of, for example, a cholera epidemic, thinking about some of these resurgence of diseases, since January, for example, there are a lot of cases across Africa, like Malawi, and also a few other countries where cholera was basically over. I know for a few years there were no recorded cases. There is more resurgence of that. There were a little bit of discussion, especially also the role of vaccines, and whether before 2018 they were sent just as a treatment, after the emergency, as we were discussing before. So where cases would appear, they would send out vaccines to slow down the epidemic, like the outbreaks. But now WHO changed the guidelines, and so countries are able to get the vaccine in advance, try as a prevention. So I think I will be interested in exploring a little bit more that type of prevention versus treatment, potentially with that change in mind in terms of water-related disease.
Other questions? So much.
Thank you very much. Thank you.